I'm Barbara Van Allen. I'm president of the Economic Club of New York. Our chairman, Terry Lundgren, had to travel this week, so he asked me to do the honors. It's my pleasure to introduce our guest speaker this morning, Larry Merlo, president and CEO of CVS Health. As you all may know, it's quite a large company with $177.5 billion in net revenue for 2016. It touches more than 100 million people each year through its unique combination of assets, including more than 9,700 retail pharmacies, 1,100 walk-in medical clinics, a leading pharmacy benefits manager with nearly 90 million plan members, a comprehensive provider of pharmacy services to long-term care facilities, and expanding specialty pharmacy services. Under his leadership, the company is working to transform healthcare by delivering breakthrough products and services that enable people, businesses, and communities to manage health in more affordable, effective ways. As part of the commitment to public health, in 2014, the company announced the landmark decision to be the first major retail pharmacy to eliminate tobacco sales in all its stores. And to reflect the broader healthcare commitment of the company, they subsequently changed the corporate name to CVS Health. So Larry is a pharmacist by education. He joined CVS Pharmacy in 1990 through the company's acquisition of People's Drug Stores, which I grew up going to here in the Mid-Atlantic. Prior to assuming the role of president and CEO in 2011, he held positions of increasing responsibility, most recently president of CVS Pharmacy. Under his leadership, the company has completed a series of highly successful acquisitions and delivered significant organic growth in major markets across the country. A graduate of the University of Pittsburgh School of Pharmacy, Larry serves on the board of the National Association of Chain Drugstores and the University of Pittsburgh Board of Trustees. He's also a member of the Business Roundtable. Today, our format will include some opening remarks from Larry, followed by a fireside chat with our club member and Fortune Time anchor and special correspondent, Susie Garib. We'll reserve, as we always do, 15 minutes at the end of the program for questions from our members and their guests, as is our practice at breakfast. Please keep in mind that the program today is open to the media. We do have media in the back of the room. It is on the record. And be assured, as always, that we'll wrap up promptly at 9 a.m. Larry, the podium's yours.
Well, good morning, everyone, and thank you, Barbara, for that kind introduction. And certainly the Economic Club of New York has a very long history of promoting serious discussion on some of the most important economic, social, and political questions of the day. And it's certainly an honor for me to be able to be here with you this morning and share my thoughts on some of the pain points that exist in our country's healthcare system. And I'll start with the fact that the current system was built to provide acute care in a fee-for-service world, not to provide coordinated care to the chronically ill, who now make up about 1/2 of the U.S. population. Nor was it designed to meet the changing demands and expectations of patients who are increasingly looking for more value, greater convenience, and more help in making healthier choices every day. And the result of all of this is a fragmented system that has produced high costs and, let's call it, not so good health outcomes, and one that many patients experience as a maze of confusion. And many of you have experienced these challenges not only as patients or caregivers, but also as business leaders and employers. So today I thought I would focus on 3 of the more significant pain points, and that's the rising costs of healthcare, the challenges in accessing primary care, and the growth of chronic disease. In addition, I'll discuss some of the shifts that are needed to improve outcomes and drive down spending, and some examples of some sensible market-based approaches and opportunities to do so. So let me begin with that first pain point, rising costs. If you go back and look at healthcare spending, healthcare spending as a percent of GDP, it was 5% back in 1960. And today it's on a trajectory of 18%, approaching 20% within the next 10 years. And That extra 2 percentage points would amount to more than $250 billion, undermining our country's ability to fund every other critical priority, whether it's education, infrastructure, certainly that list goes on. And these cost increases have a huge impact on the budgets of employers, public programs, and they are increasingly affecting the pocketbooks of everyday Americans, and here's why. First, employees' health premiums have been rising at about twice the rate of salary increases. Second, more employees are enrolling in what is referred to as high deductible benefit designs. And today nearly 30% of covered workers are enrolled in high deductible plans, and that compares to about 4% a decade ago. And these plan designs are intended to introduce more consumerism into the healthcare system. However, you think about approaching healthcare with a consumer mindset, that's a very, very new experience for many people. And what people want is affordable healthcare, and they need innovative tools as well as simple and clear information to help them be more effective healthcare consumers. So maybe said another way, I think we've pushed healthcare accountability and decision-making towards the patient, but healthcare literacy and the tools to empower patients are lagging behind the expectations of consumer-driven benefit designs. Now, since medications are involved in about 80% of all healthcare treatments, one significant opportunity to lower costs for consumers is the way in which prescription drugs are procured, priced, and managed. If you look at the pharmacy landscape today, more than 87% of prescription drugs dispensed all across the country are generics. And if you look at the average out-of-pocket cost for one generic drug that may be taken as part of a chronic disease, as part of one's daily regimen, the annual cost to that patient is less than $70, annual cost. And we've heard a lot about prescription drug pricing, so you turn around and say, wait a minute, less than $70 for a year, 87% of the prescriptions, so what's the problem? Well, the real problem relates to that other 13%, which are brand name drugs. And pharmacy benefit managers, are commonly referred to as PBMs, they do an effective job in driving down drug prices for their clients, whether it's an employer, health plan, or government clients. And over the next decade, PBMs are projected to save clients more than $650 billion on drug costs. And they do this by leveraging the purchasing power of millions of Americans and by deploying a variety of tools and capabilities to ensure that their clients and their clients' members receive the right pharmacy care at the lowest possible cost. Now, traditionally, physicians have not had visibility into their patients' benefit plans to know what programs are available for each of their patients, or the costs associated with the various medication options, or where patients may be at in their deductibles. And with the growth in our business of electronic prescribing and electronic health records, that's no longer the case. It is now possible for PBMs to transmit important benefit and formulary information to both the patient and the physician through the patient's electronic health record. You can provide drug pricing and other valuable data at the point of prescribing. And this creates an opportunity for more informed dialogue about the most appropriate course of treatment, which can prevent what we refer to as sticker shock that many patients experience today at the pharmacy counter when they go to have their prescription filled. And it's bigger than just pharmacy. There are similar opportunities that exist across the entire healthcare system. And take MRI scans as an example. According to data that has been compiled by Medicare, an MRI could cost you as little as $470 or as much as $13,000, depending on where you have it performed. At the same time, there are billions of private sector dollars being invested in developing more cost-effective comparison tools and other technologies, whether it's mobile applications, wearables, cloud-connected devices. And all of this is intended to help individuals and their physicians make more informed decisions about health and their health care. And as patients continue to take advantage of these new tools and act more like consumers, they will help spur even greater competition among healthcare providers. And we think that that will go a long way in helping to lower the overall cost of care. Second major pain point, access to primary care. Most experts agree that primary care physicians should serve, as the medical home for all patients. However, the expansion of health coverage is part of the Affordable Care Act, and 10,000 Americans reaching retirement age every day, and that's going to continue for another decade. The system is becoming overwhelmed by the increased demand for service. In just the last 3 years, the average wait time for a physician appointment in large metropolitan areas has increased by more than 30%. And it's projected that by 2020, it's only 3 years away, that the U.S. will experience a shortage of more than 45,000 primary care physicians. Making matters worse, patients without a primary care physician or who simply can't get an appointment, what do when they're sick? They often turn to the least cost-effective site of care, and that's the emergency room. So clearly, there's an opportunity to help consumers more easily access health services, whether it's in their communities, in their own homes, or through digital tools. And that's why one of the most encouraging changes taking place in healthcare today is the expansion of lower-cost sites of care. And we've been calling this the retailization of healthcare, and we think it's just getting underway. As an example, urgent care centers, walk-in health clinics, they're growing rapidly. They're up to 80% less expensive than the emergency room for the services that they provide with the same or even better outcomes. We think this makes them an ideal complement to primary care. Another convenient option is in-home care, where treatments such as infusion services can be provided at a much lower cost than in a medical facility and with greater comfort for the patient. And as the population ages, we think this will become an increasingly attractive option for those who prefer to, let's say, age in place. The next frontier of accessible care is telehealth. Imagine how different, our healthcare system will look when millions of Americans, can use an app on their phone to teleconference with a physician from maybe a walk-in clinic, or perhaps their home, or maybe a hotel room, halfway around the world. That's where healthcare is headed, and the future is not that far off. I do want to emphasize that these additional care options do not replace primary care physicians. They complement and extend primary care. In addition, it's critical that the care provided through these and other low-cost sites be connected and integrated through the patient's electronic health record to avoid the risk of fragmented care. So that leads me to the third and final pain point, and that's the growing prevalence of chronic disease. I referenced earlier, today 1 in 2 Americans have at least one chronic disease, such as heart disease, hypertension, diabetes, and the numbers are growing. Today it's estimated that more than 80% of all healthcare spend goes to treating chronic illnesses. And ineffective management of these conditions and the medications associated with them is estimated to cost more than $300 billion per year in avoidable costs. For example, research indicates that about half of all patients in the U.S. do not take their medications as prescribed. And up to a third of prescriptions that are written never even get filled. This leads to, as you would expect, some serious consequences. Today, about 1 in 5 patients who are discharged from the hospital are readmitted within 30 days. About 3 in 4 of these readmissions are preventable, and 2 in 3 actually relate to a medication issue. This is simply unsustainable, particularly as the population ages and more Americans transition across care settings, such as the hospital or the home or into some long-term care facility. So there is tremendous opportunity to make healthcare much more effective by engaging with patients more frequently where they are and coordinating care to make a complex system much easier to navigate. And we certainly see pharmacy care playing a significant role because you think about a patient with a complex disease like diabetes. They will visit their pharmacy more than 30 times a year. Okay, that same patient, if they see their physician on a quarterly basis, 30 times in the pharmacy, 4 times in the doctor's office. So pharmacists can play a more active supporting role in each person's unique health experience, from advising them on the best use of their medications and improving medication adherence, or helping to coordinate care more effectively among a patient's healthcare providers. And research has shown that programs that include one-on-one counseling between patient and pharmacist are 2 to 3 times more effective at improving just medication adherence than any of the other interventions that are possible, and they result in cost savings of about $3 for every $1 invested. In addition, the ability to analyze big data has enabled interventions in pharmacy care that can support pharmacists in ensuring that patients receive high-quality care. And at CVS Health, as an example, we have developed what we refer to as the Health Engagement Engine. And this engine not only analyzes our own pharmacy data, but it also looks at data from other payer sources, including health plans, providers, and health systems. And this creates a much more holistic view of the patient, along with the ability to exchange information with the insurer and the physician through the patient's electronic health record. For example, we can notify doctors when patients are not refilling their prescriptions, and doctors can alert us to patients who have some very complex regimens where we may be able to provide more support by helping to synchronize all of their prescriptions onto a common fill date. We've even developed a pretty accurate way to predict when fragile patients might need extra support, such as when they're about to be discharged from the hospital or transitioning perhaps into a skilled nursing facility. And by intervening at these critical moments, we can help prevent some of those costly readmissions that I alluded to earlier. Now, utilizing this data we see it as a crucial opportunity in healthcare today. Today, I would describe the system largely analyzes data reactively to determine the cause of a health event after it occurs. Going forward, the ability to translate data into actionable information proactively, predicting and preventing events before they happen, I think that will really start to move the needle in a way that produces better outcomes at a lower cost. So let me conclude where I began, okay, and that's that the healthcare system that we have today, it wasn't built to adequately address the pain points that are all too familiar to us. And fortunately, there are many opportunities to improve outcomes and drive down costs, and I am optimistic about the changes that have been taking place. At CVS Health, you think back to Barbara describing the capabilities that we have. We think of ourselves as being the front door to healthcare. We touch the lives of 1 in 3 Americans, and we're playing an active role in providing more affordable, accessible, and effective care. And we're not alone in this effort. There are tremendous investments that are being made in private sector innovation to improve healthcare and reduce spending, and market forces are helping to increase choice and competition, empower patients as consumers, and to make this complex system easier to navigate. At the same time, there are important public policy changes that can be made to help accelerate these opportunities. And just to mention a few, let's continue to increase competition in the prescription drug market. Today, there is a backlog of more than 3,000 new generic pharmaceuticals that are waiting approval by the FDA, giving priority review to drugs for which there is no competition and increasing speed to market of new biosimilars. And I know the new FDA Commissioner, Dr. Scott Gottlieb, shares these priorities, and I applaud him for the actions that he has been taking. Second, let's accelerate consumerism by modifying the rules around health savings accounts. I know many in this room, you probably have that as part of your health insurance. Currently, the rules allow employers to cover certain preventive drugs for chronically ill patients at little or no cost outside of the patient's deductible. However, patients are required to start paying for their drugs as part of the deductible once they get sick. Now, you may be sitting here at this point saying, Larry, you got that backwards. No, I didn't get it backwards. And we believe that plan sponsors should have the option to cover all prescription drugs for little or no copay outside the deductible at any time, if that's how they choose to structure their benefit. Now, third, given the importance of their role, let's empower pharmacists to spend most of their time taking care of patients. not doing administrative work, and allow them to practice to the top of their license. I know all of you have a huge stake in the debate over the future of healthcare, so I hope you'll stay actively involved. Before I conclude, I want to say a word about a very important topic in healthcare, and that's the alarming and heartbreaking opioid epidemic. You know, in the last 2 decades, opioid prescribing rates have increased nearly threefold. This remarkable volume of opioid prescribing is unique to the United States, where prescribing in 2015 was 4 times what it was in Europe. This epidemic has no single cause. It doesn't discriminate. It exists in our cities and the suburbs, across rural America, among all socioeconomic groups. And addressing it requires a multi-pronged effort involving all healthcare stakeholders, whether it's physicians, dentists, pharmaceutical companies, pharmacies, insurers, and government officials. At CVS Health, we will continue to be actively engaged and do our part. In the last 2 years, we've worked with local law enforcement across the country to collect and safely dispose of what now amounts to more than 100 metric tons of unwanted medications. And next year, we'll double down on these efforts, installing another 750 drug disposal collection units in retail pharmacies across the country. We've worked and partnered with now more than 43 states to expand access to the opioid overdose reversal drug, naloxone, to help save lives and give people a chance to get the help they need for recovery. We also have a program that we refer to as Pharmacists Teach. We have 30,000 pharmacists all across the country, in local communities across the country, and these pharmacists go out into their communities, into the schools, to educate students about the dangers of prescription drug abuse. And to date, we've now touched more than 300,000 students through this program. One of the most difficult challenges, however, is changing prescriber habits for, I'll call them acute injuries. How many of you have had the experience where maybe it was a dental procedure or some acute, ankle injury, knee injury, and you've left the office with a prescription for 30, 40, 50, 60 powerful pain pills? And I see a lot of head nodding, okay? As a leading stakeholder in pharmacy care, we believe it is time to institute limits on the quantity of opioids dispensed to patients who are receiving opioids for the first time, and to ensure that the prescription fits the medical condition. So utilizing our retail pharmacies and our PBM services, we will work with physicians, patients, plan sponsors, and other stakeholders to limit to 7 days the supply of opioids dispensed for those certain acute prescription needs, while continuing to ensure that patients that have critical chronic needs continue to have access to appropriate care. So thank you again for the opportunity to share my thoughts with you, and I look forward to the discussion with Susie.
That was great.
Thank you, Larry, for those insightful remarks, and we'll now start into the fireside chat.
Thanks, Barbara. Larry, I'm sure everybody in this room has a personal story that they could tell you about their pain points. So thank you so much for your presentation. It's really great. I'd like to pick up on where you just left off on this opioid crisis and the new policy that you put in, 7 days limit on a prescription, and as opposed to the 18-day, 20, 30, whatever it's been. So it's been a couple of weeks since you announced that. What kind of reaction have you been getting, whether it's from doctors or patients or other drug makers?
Susie, it's a great question. And if you go back, and I think one of the things that we learned, I talked about what we've done around drug collection, empty out those medicine cabinets. And I think one of the things that it hit us, I think we were all shocked. Over 100 metric tons, that's over 200,000 pounds of unused medication. So you sit here and say, well, if we could go and empty every medicine cabinet in America, by the time we're done, it'll be time to start over again, because we have not solved for the root cause. Why are these meds, there to begin with? So, that was really the trigger point in terms of, how do we get to the root cause? And the root cause is, the prescribing habits that physicians have gotten and dentists have gotten accustomed to automatically writing for that quantity of 30 or 60. So that's how, all of this began. I would say we've had a tremendous outpouring of support, and, we've gotten countless emails from our customers who want to share their story. And many of them are heart-wrenching, okay? That, Susie and I were talking earlier. I got an email from a mom who talked about her son who was a football player, okay? And, got a football injury, went on an opioid, okay, and became addicted. And, and he's now in his late 20s, and he lives with that addiction challenge every day and has been, into recovery multiple times. And, and she went on to describe, stick to your guns because we've got to change this for the next family that, might incur the same scenario. So, we've gotten those responses. We absolutely want to work with physicians because, the challenge in this is, how do you separate the acute need, okay, from, perhaps, that cancer patient, okay, or that person who has, chronic needs. And that's why this is a collaborative effort between, our retail pharmacies and our PBM services that, we're confident that, we can ensure that, again, working with patients and physicians, that we can, identify the right people who, we can start with a 7-day supply.
So you said it was pretty supportive. I mean, was the reaction you were expecting?
Yeah, Susie, I think that we expected that, there'd be a lot of questions in terms of, how are you going to do this so that we don't, deny care, okay, to those patients who need it. We're comfortable that we have an answer around that. Listen, every day this is in the news, okay? I think people are looking for a solution. Much like we talked here, I saw a lot of head nodding and a lot of, hands raised. I think everybody can relate to the fact, those circumstances where you left the doc's office and why am I sitting here with 30 tablets? I don't need that. Mm-hmm. So, I think we expected, that type of reaction, and that's what we've seen today.
What about from other pharmacies? Are they going to follow your lead?
Yeah, Susie, it's a great question. Certainly, I think other companies are going to have to make the decision that, they believe is right for their business. I will say that, this is not a competitive issue. We have had discussions with our competitors, both on the retail pharmacy side as well as, on the PBM side, that, listen, working together, with a common cause, we can make an even bigger impact. And there's a lot of discussion taking place there. So, Susie, I have optimism that we're going to have others join us in this regard.
But in your experience, when you decided a couple of years ago to remove cigarettes and tobacco sales from inside your CVS stores, there weren't many fast followers that imitated, copied you. Now, cigarettes is a serious health issue. So are opioids. Do you think this time it'll be different? Do you think you'll get a different reaction from other pharmaceutical, drugstore chains and whatever?
Susie, again, I would hope so, okay, because it's simply, the right thing to do. I think on the tobacco decision, listen, we knew that was the right decision for our company as, we were becoming, more of a healthcare company. And, I see my good friend Mark Bertolini from, Aetna here, and, I remember Mark and I talking about that decision that, how do you have credibility to do all the things that we talked about this morning, and at the same time, you're delivering healthcare in the back of the store, and you're selling tobacco products, in the front of the store. And we saw that as a credibility and an integrity issue in terms of what we were doing and what we were becoming and evolving to as a company.
I want to stay on so just a little longer, push you a little bit more about, have you talked to your competitors like Walgreens or Walmart about your announcement and, hey guys, are you going to do the same thing? Come on, step up.
Yeah, Susie, we have had those discussions. And
since your announcement?
Well, actually leading up to the announcement. And, we've talked about it as part of the trade associations that exist both on the retail side as well as the PBM side.
So what do they say?
I think there is a lot of discussion taking place in their respective offices in terms of, what they should do. And as I mentioned earlier, I can't speak for what they will do, but I think there's optimism that, we need an industry solution. And it will be better for all of us if we can, develop, a singular solution. And I think it'll be much easier for everyone to rally around and, to execute.
And so this whole thing kicks in February 1, 2018, so there's some time to work it out. So how is this going to work? A patient goes into comes into CVS and says, my doctor gave me this prescription, but it's for more than 7 days. Then what happens?
Yeah,
You're going to call the doctor, and what is the doctor going to do? And are you guys going to have to battle it out?
Yeah, and you know what, Susie, I don't know that I look at it as a battle, okay? And again, I think that, using the services of our PBM, okay, that will be important in terms of, understanding this is a chronic needs patient, okay? This patient is a first-time, opioid user. So I think that's, an important dynamic. I'm optimistic that, as this begins to gain traction in the marketplace, I do see prescriber habits beginning to change. That I know I've personally had a number of discussions with, some physicians that I know, and it kind of falls under the heading of just kind of force a habit in terms of, what they've been accustomed to. So I think it will take some time, but I do believe that, at the end of the day, we will make a meaningful difference in what we're doing here.
So you said in your talk that this is going to require a multi-pronged effort. So you took the first bold step here. What's the next step?
That's a great question, okay? And Susie, I think that, we think about our actions being focused on, prevention, education. We talk a lot about collection and partnering. And, and I think we'll continue to get learnings, okay, as we do more things. And, it's hard to sit here and say what's next, okay, but, I think as an industry and as being one of the stakeholders, okay, that has a responsibility for, developing solutions, I don't think we can rest until we know that, this trend is not accelerating, it's beginning to decline. And listen, one of the things that, we have seen from, the actions that, we have taken over the last 4 years is, we've seen a decline in the number of opioid prescriptions that we dispense in our pharmacies by as much as a third. So we know the actions that we have taken to date have made a difference.
So I understand that New York Attorney General Eric Schneiderman has contacted you, contacted CVS. What role can he play? What can he do in your efforts to move this along? You said earlier that government officials have to get involved in this.
Yeah, Susie, there are a number of opportunities out there. We talked a lot about, I mentioned electronic prescribing, okay? And, today about 65% of all prescriptions that are written, get to the pharmacy through electronic prescribing. We know that is one of the best methods with which to reduce the risk of fraud and abuse. So, mandating electronic prescribing of all controlled prescriptions, that would certainly, support, everyone's efforts. I think the other thing that exists, and it's referred to as prescription drug monitoring reports or programs. They exist at the state level, okay? And, a pharmacist can go to one of those reports and to, see if this particular patient, has had multiple prescriptions from perhaps, multiple pharmacies. And they're clunky to use. I think the big challenge around that is they exist at the states. There's no national, program, okay, and there's no national standard. So the ability to, enjoin these state programs around a common solution, you think about, the border towns in states, and it becomes very, very difficult for a pharmacist to be able to triangulate, when oh, gee, I might have to access 3 or 4 different states, monitoring programs, to answer a simple question. So I think those are just a couple of examples in terms of, how government officials can help move some things along that we know will make a difference.
So I'd like to move along to drug prices, and I'm not going to get into the whole sticker shock and he said, she said, what the drug makers say about the PBMs and what the PBMs say about the drug manufacturers. But I do want to talk to you about Amazon. The word is that Amazon could be getting into the pharmacy business and selling drugs online. What do you think about that?
Well, listen, we have, as an industry, we've seen, new competitors, enter and emerge. I will say, and listen, Amazon obviously has become, in many households across the country, and listen, they do a great job. And, they have changed how, America thinks about, shopping and have defined convenience perhaps, in different ways. For many of the reasons that I touched on earlier, pharmacy is, we shouldn't confuse pharmacy with a book, okay, or, a product. There is a service component to pharmacy that, that is very different, okay, and, the barriers that exist or the barriers to entry, okay, with pharmacy are different, okay, than, what you might experience with other products.
So are you saying that's going to be difficult for Amazon to come in and disrupt the drug selling business compared to the food business or any other area that they get into?
Well, Susie, I'm saying it's different, okay? And, I mean, you think about, pharmacy operates mail order. We have mail order pharmacies today. Some of our competitors do the same thing. If you had the opportunity to visit one of those mail facilities, they would look more like a manufacturing facility than they would a distribution center. So I use that as a contrast in terms of how some of the elements are different. But listen, if Amazon were to enter that space, I'm sure that as an industry, the industry would respond. There are a lot of things that we do today that we see as unique, and there's more that we can do. Okay, and I think one of the opportunities that we have is, you think about the fact that we have almost 10,000 pharmacies across the country. We operate a mail order pharmacy. Today about 80% of the U.S. population lives within 3 or 4 miles of a CVS. So you think about the opportunities that we have that, as a consumer, okay, you can say, well, wait a minute, I want to pick my prescription up at CVS, or I want to have it mailed to my home, or, what would it mean if we said we could deliver it to your home, okay, or deliver it to your office, okay? So we have, all of those capabilities today that I think would allow us to, to compete in a world that is evolving.
Well, I'm sure that Amazon would have some kind of fantastic delivery thing that we haven't thought of, but it's not so much the delivery part of it. For the people who are familiar with what Amazon has been talking about internally, is that they might want to eliminate the middleman, and that means the PBMs, that means companies like CVS, and then pass along those savings to consumers. It's possible they're going to be talking about ways that consumers can comparison shop to find out what different prices you can get for a certain drug. So if that does happen, let's just say hypothetically, if that were to happen, what is the CVS strategy?
Yeah, and Susie, I am confident that, as our strategy continues to evolve and, that, we will be an effective competitor, in the marketplace. There is a role. We talked a little bit about the role of the PBMs in terms of, driving down, the price of pharmaceuticals.
Right.
And listen, there's a lot that can be done. I know we have some of our clients here in the room that, we're proud of the fact that if you look, in 2016, our clients' drug spend year over year increased about 3%. Left unmanaged, drug trend for 2016 was almost 12%. So, the role of the PBM is critically important. I think what makes, CVS Health unique is, the role of the PBM combined with our capabilities, with our retail pharmacies and, our specialty pharmacy business and, some of the, assets and attributes that, again, Barbara touched on, connecting the dots across those different assets allow us to provide differentiation in the market that is unique and, and certainly goes a long way to, hit on those 3 variables of access, quality, and cost.
Well, on that subject of access, quality, and cost, let's talk a little bit about the Affordable Care Act. What do you think of the new proposals and executive orders that President Trump just signed? What do you think of them?
Yeah, Susie, listen, I think that, if we start with what is it that everybody agrees with, okay? I think that, it's safe to say that I think everybody believes that, we should be able to, provide affordable access to health care for all Americans. I think the debate, okay, and the ongoing debate has been exactly, how do we get there, okay? And I think that debate is gonna continue, okay? I think, I am optimistic that we'll eventually, find the right answer, okay? I think we're doing what we can, okay, in terms of, jumping into those discussions, in terms of talking about, opportunities that we see, okay, that, we think are not being, leveraged or capitalized. And, one of them we touched on earlier is how do we think about where the care is administered as a variable of care? And, I would sit here today and say we do not put enough focus in terms of, valuing, the opportunities that we have, not to compromise the quality of care, but to provide care in a lower cost care setting, okay, that, will ultimately reduce, the cost of care.
But specifically to what President Trump, these early new actions that he's been doing, he says that his proposals will get low prices for great care. And the experts are saying it'll actually make care more expensive, especially for people who are really sick. So what are your thoughts on that? I mean, what do you think of the direction he's going in?
Well, I don't believe that we can, that we can piecemeal, okay, some of the dynamics, that exist today, because, it's, every action, has, an opposite action, as you go down, the different, components or dynamics, associated with healthcare. So I think it becomes very difficult, okay, to, look at one aspect, okay, without, also, talking about, okay, what is the unintended consequence associated with an action here that, and that's why we talk a lot about whether it's, back to, site of care, the role that, pharmacy can play, in reducing, the cost of care, that $300 billion that, that I talked about. And there's not enough focus, okay, that, if you do this, okay, then, maybe there's an opportunity to, work in this particular area. And, that, I think that's a little bit of what has, everyone a little frustrated.
Oh,
Okay,
it is frustrating. It's a very complicated issue. And as you said, you touch one thing and then you have something somewhere else. Do you think we'd be better off, Americans would be better off, keep Obamacare as is with its flaws? Would you favor that?
Well, Susie, I think that, there is, if you go back to those three variables around access, quality, and care,
Right.
I think that most would agree that, the Affordable Care Act, no question, that, it improved access, okay? We saw, more Americans have access to care, largely through, Medicaid expansion. There is, evidence out there that, it improved elements of quality if you consider preventive care as a measure of quality, okay? I think what most would also agree with, that it did very little, around cost. And, and it's, I would sit here and say that our action should be focused on how do we solve the cost equation component, of those three variables. And
Do you have an answer to that question?
I have many answers to that question, okay?
What would you, as the CEO of CVS, this very powerful healthcare company, what would you like to see?
What I would like to see is, we touched on, how does site of care play a role in overall health care, okay? And one of the arguments that you get is you're fragmenting care, okay? I don't think that, I don't think that has to be the case, because we can create a connected care experience through the electronic health record. I think that's one element. I think pharmacy has to be recognized in a bigger way for the role that it provides. We talked about the fact that the pharmacist should be able to practice to the top of their license, okay? Today, pharmacists work with their hands too much. They're doing administrative tasks. You know, we need to get them to use and work with their minds. Same thing can be said of nurse practitioners. I think, you know, they continue to be the most accessible healthcare professional, you know, that, you know, exists across the supply chain, but yet we're not utilizing their talents in a wholesome way. So, you know, certainly it can start there, okay? And there, you know, if you start there, there are many, many benefits that can derive.
All right, let's open it up to questions.
Great.
Okay. I caught you. Yes, over here. Let's get a microphone so everybody can hear your question.
Hi, Larry. Thank you. Thanks. I was listening to you talk about the opioid crisis and the rising dynamics around that. And I wondered if you would make a comment on whether you see there being a future in medical marijuana and how that might help in long-term care, and how a company like CVS, who operates in the mainstream of healthcare, would feel about that.
Yeah, it's a great question. And, you know, I think one of the questions out there is, you know, is marijuana a gateway drug? Okay, and, you know, if you talk to the clinicians, there's evidence on both sides of the equation, okay, that, you know, some say it is, okay, and some say it's not. I do believe that, you know, that is a concern for society, okay, that to the extent that, you know, it is a gateway drug, then, you know, we've got an additional challenge that we have not seen, you know, that dynamic evolve at this point in time, okay? If your question is, do you see us dispensing, you know, medical marijuana, I don't see that, you know, certainly in the near future.
Why
okay?
not?
You know, it's today pharmacies are not licensed, okay, to, you know, dispense, you know, medical marijuana, okay, and I don't believe that there is, you know, enough, you know, evidence that, you know, would constitute that as part of our practice today. And, you know, Susie, if you turned on and said, tell me more about what you're talking about, there's no standard in terms of the concentration of, you know, the active ingredient in marijuana, THC, okay, that, you know, so it starts there.
Okay, more questions? In the back there.
Thank you very much. So you were talking about the future of healthcare in the sense that the industry would have to leverage big data analytics more and expand the access to information between doctors and pharmacies and healthcare professionals. And I think the challenge that the industry would need to balance is to make a highly sensitive information wider available. So as a cybersecurity professional, I'm wondering, what is your vision for securing this highly sensitive information and preventing insider threats?
Yeah, there's no question that, you know, cybersecurity is, you know, is certainly a new dynamic, okay, and, you know, one that we spend a tremendous amount of time on, you know, in our company and in our boardroom, okay, and, you know, and it's, you know, it's not a once in a while, you know, focus. It's become an everyday focus within not just our IT shop, but, you know, the entire organization. Because, listen, you know, we've got 243,000 colleagues across CVS Health, and, you know, cybersecurity is not just, you know, an IT function. You know, we all own it in terms of what we do to, whether it's protect our passwords and some of the things that, you know, occur today with phishing and, you know, and whatnot. So, you know, we will continue to have, you know, an ongoing focus. I think, you know, one of the debates that's out there, okay, is as we move forward with some of these more advanced programs, do they become more opt-in programs for the patient, okay, versus, you know, what exists today? And those are discussions, you know, that we are having. I think that, you know, the opportunity to, you know, provide that coordinated care and, you know, and for the patient to see the benefits in that, I do believe that, you know, that becomes our responsibility. And, you know, patients seeing that benefit, I think that it's something that, you know, they will want to have as part of, you know, their their portfolio or their regimen.
Okay. I saw a couple other hands that came up. Sir?
Yeah, hi, thank you. And thank you also, applaud your decision in removing tobacco products, so thank you again
Thank
for
you.
that. Question around, you mentioned compliance as being certainly an issue, and the EMRs being an opportunity in connection with the physician offices. What other technologies do you see coming down the pike that could be helpful in ensuring better compliance to taking medication?
Yeah, it's a great question. And, you know, I mentioned, you know, the investments that are out there, you know, in new devices. Just as one example, we are in the process of rolling out a program that, you know, for diabetics, where, you know, we actually have a connected glucometer, okay, that the patient receives, okay, and, you know, we're actually able to measure their blood glucose levels in real time via the cloud. So, you know, we have clinicians that are, you know, that have the responsibility for that monitoring, and when the bells go off, if you will, okay, then we get in touch with patient and or caregiver, okay, in terms of intervening at an appropriate point where without that, okay, the intervention may have occurred in the ER, okay, when, you know, when perhaps, you know, other, you know, complications or consequences were setting in. So I use that as an example of, you know, kind of where the world's headed, okay, and I think there'll be more opportunities like that as we go forward.
CVS Health has been at the forefront of the issue of the gap between the payment of its highest officials and its ordinary workers. What, if anything, have you done about that, and what are some of your views?
Yep. Yeah, I think that's going to be a question and a debate that, you know, will rise as we comply with, you know, the reporting standards in next year's proxy season, okay? But, you know, listen, I can assure you that, you know, our board of directors, okay, that's something that, you know, we have a lot of discussion and, you know, gets reviewed on an annual basis. And, you know, not just the executive officers, but, you know, our executives broadly, okay, you know, our board has a pay for performance, you know, objective, okay, and, you know, the, you know, compensation, you know, is reflected in the performance of the company, okay, and there's absolute alignment in terms of, you know, the goals, the performance, you know, and the ultimate, you know, pay. You know, as it relates to, you know, our workers, you know, our colleagues across the company, we have, you know, a very dynamic, you know, evaluation process that, you know, ensures that, you know, our employees, you know, whether we're talking about our nurse practitioners, our pharmacists, our managers, you know, have competitive, you know, pay practices, okay, and, you know, that, you know, includes not just, you know, the base pays, if you will, but, you know, the benefits that are associated by being a colleague, okay, as part of CVS Health. So, you know, I think in summary, it's something that, you know, we spend, you know, the appropriate amount of time, you know, evaluating on a regular basis. And, you know, we're very comfortable in terms of, you know, the standards with which, you know, we manage the business by.
I think we have time for a few more questions. The gentleman over there.
Hi, thank you very much for the presentation and discussion. One of the cornerstones of CVS Health, I would think, is the pharmacists themselves, whether you're talking about the competition with Amazon, interacting with doctors, and more importantly, the consumers when they go into CVS, everything that you're talking about, whether it's TV or whatever, is being seen and firsthand in terms of their interaction with the pharmacist. What does CVS do to ensure that once a pharmacist becomes part of the CVS family, that they're really the best of breed? You know, whether it's the educational programs they're getting, whether it's an ongoing courses they have to take or whatever, to ensure that that step out there, that face-to-face with the patient or caregiver, is really the best in the industry.
Yeah, it's a great question, and I mean, as you might expect, we have a variety of, training and education programs that, that exist, and, oftentimes get, updated or prioritized, okay, based on, what is evolving or what's new, or quite frankly, what we're innovating and rolling out, as a company. I think one of the other things that we're very pleased with is that, we have, it really starts when, these, pharmacists are not pharmacists yet, okay? They're in pharmacy school. And we have a very robust, intern program where, we're looking for the best and brightest, when they're in their second year, third year of pharmacy school. And it gives us an opportunity to see them, and it gives them an opportunity to see us and really understand, what it will be like, as a pharmacist for CVS. And, so at any given point in time, we may have as many as 2,000 interns, okay, that are, in various years of education in pharmacy school. We're very proud of the fact that, as we see them and we see us, more than 80% of those interns that we make job offers to when they finish pharmacy school come on, and become, one of our colleagues. So to me, that is, kind of one of the, the best testaments, because, we know one another, okay, as they're beginning their pharmacy career.
More questions from the audience? Do we have time for one more? Barbara? Oh, and here's, sir. Can you bring the microphone, Joanne? You get the last word.
The last word? Thank you, Larry, for your presentation. One of the biggest problems or challenges for payers in providing a prescription drug benefit are specialty drugs. 1.5% to 2% of all the prescriptions filled account for 40 to 50% of the drugs. Specialty drugs haven't had the advantage that, or the opportunity that the brand generic marketplaces had, and biosimilars are starting to develop. You pointed out that there's several hundred in the approval process with the FDA. Concerns that payers have is that the biosimilars will not have the same difference between the brand and the generic that we've experienced when you look at a regular specialty drug versus a biosimilar. Do you have a sense on that? And also, what would CVS's strategy, CVS Health's strategy be to try to improve that situation on pricing? Because pricing is such a significant component of the overall cost of a prescription drug benefit program.
Yeah, Angela, it's a great question, and and maybe I'll just I'll quickly share, when the Hep C drug entered the market, and that was, I'm going to say, 3 years ago. Okay, there was sticker shock for everyone. There was one product. It was a cure.
Oh, boy. Sorry.
It was a cure, okay, and it was a 10 to 12 week regimen, okay, at a cost of $90,000, okay. Within a matter of, I think it was 6 to 8 months, okay, a second product entered the market, followed by a third product, okay. And today, as you look at the cost of the Hep C products, okay, versus the cost in Europe, it's actually less in the U.S., okay, again, because of the role of PBMs, okay, than, what those drugs cost in Europe, and it's around $40,000. Now, I'm not sitting here suggesting for a minute that $40,000 is, inexpensive, okay, but, we saw the cost of that therapy, cut more than half, okay, and, and the reason around that was competition allowed PBMs to, those products, while not chemically equivalent, okay, were therapeutically equivalent in terms of its outcome. So PBMs were able to, sit and talk about the fact that we're only going to put one of those products in the formulary, and, we're not compromising effectiveness. Okay, we've made that determination that they're clinically effective, equally effective. So now it's about cost. Okay, so, we're spending a lot of time, in DC educating the policymakers in terms of, because, Susie, I'm surprised you didn't ask about what about the government doing, price negotiation. Okay, we would sit here and say, the government should focus on, increasing competition within these therapeutic classes to let us do what, we just described. That will bring down the cost. Okay, so, Angelo, to, the comment about we've got to get biosimilars to market faster than we're doing. Europe has probably 4 times the number of biosimilars than what we have here, in the U.S. And the biosimilars will not be priced like generics, but they will introduce therapeutic competition within, that class of products that will allow us to do the same thing that I just articulated that we saw happen in the Hep C category.
All right. Thank you so much.
Thank you, Susan.
Answering all my questions and to our audience.
Thank you. Thanks, everybody.
Many thanks again, Larry, for joining us this morning, and Susie for a great interview. I want to remind everyone that we have an exciting lineup next week, starting with a breakfast with Congressman Richard Neal. He's ranking Democrat on the House Ways and Means Committee. He's going to talk about tax reform. Then we have at Bloomberg on the 24th, our first class of fellows here at the club are going to face off in 2 debates, one on artificial intelligence and another on blockchain. So that should be pretty exciting. And then third, next week, on the 25th, we have with us the Secretary of Commerce, Wilbur Ross, so we hope you'll join us for that as well. So we hope to see you at those upcoming events, and thank you for joining us. Have a great day.